So we're going to explain the next few things with a diagram. This is your urethra, your bladder, and your prostate. So just to be really clear, the purpose of surgery is to remove everything between these two dotted lines. So all of this is gone. So you can see straight away, of course, that we therefore need to reconnect this bit here to this bit here. And that involves bringing the bladder down, but also the urethra up slightly. So you actually lose about 1.5 centimetres to 2 centimetres of penile length from this kind of surgery. And there's evidence that shows that if you don't warn men about this in advance, they can find it quite psychologically disconcerting. Now, the good news, of course, is that this does come back, but it takes on average about 10 months for the muscles to all settle down. The next thing to mention is the join between here and here, the anastomosis we call it, which incidentally is made much easier with the magnification that we get from the robot. It can leak. About 1 in 50 men get a leak from this join. And we fix that by leaving the catheter in, which normally stays in for a week to 10 days, for a further 2 weeks. The next thing to mention is that you can develop some scar tissue at the junction, called a stricture, and that normally reveals itself 2 or 3 months down the line. Usually what happens is that your urine flow gets much better after surgery. If that were to slacken off, then this is normally why. You let us know and we pop a telescope in and snip it open. The final thing to mention is that all the little ducts that bring your semen into your ejaculate, they all come in through the prostate, and so they're disconnected, and therefore any ejaculation that you have after surgery is dry. I want to briefly mention lymph nodes. So there are some lymph nodes around the edge of the pelvis. And we don't normally take a sample of these for men with intermediate risk cancer or even low risk cancer, because there are risks with doing this part of the operation. But for men with high risk cancer, we think it's worth it. That's because there could be some small cells that have gone off into the lymph nodes, even though we can't see them on the scan, when we need to know about those because it helps us plan further management. But the risks are related to the structures that go through this area. So there's a big nerve, which is really important for supplying power and sensation to the inside of the thigh. So some men do experience some weakness and numbness in the thigh for a few weeks after surgery. These lymph nodes also are there for a reason. They drain all the lymphatic tissue out from the leg. And so with this all disconnected, a couple of things could happen. You could either get a build-up of lymphatic fluid in the leg, leading to leg swelling called lymphedema, or the lymphatic fluid continues to pour out into the pelvis in the absence of the nodes, and you can end up with a bit of a collection building up. Now, interestingly, I think most men get this, but only about 1 in 10 actually know about it and need a drain inserted, and it's usually because it causes pressure or potentially could get infected and therefore needs draining. Okay. So there are 2 final things which most men want to know about it. The first is continence and the second is erections. So we'll start with continence. There's a muscle down here around the urethra, below the bladder. It's a circular muscle and it's really important for keeping the bladder closed. Now initially after surgery it doesn't work as well, partly because it's used to being in this position. As I mentioned, we've hitched it up so the angle's changed, and also because the electrical current that we use during surgery can stun it for a period of time. So initially, when the catheter comes out at a week to 10 days, you will leak at first, and you wear pads to deal with that. And we teach you how to do these things called pelvic floor exercises. And the idea with pelvic floor exercises is that you bulk up the muscle, strengthen the muscle below the bladder. It's a bit like going to the gym, and also improves your brain's subconscious control of the muscle. So the idea is that in time it becomes natural just to close off this muscle and keep your bladder dry. But it does take a bit of time. On average, it takes about 6 weeks to be dry at night and another 6 weeks to be dry during the day. Only 3% of men have a long-term problem with continence, but that is 3%. So 3 in 100 men will have issues with leakage that need fixing. Now, of course, the flip side is that 97% of men are fine. And just to be clear what I mean by fine, that's either completely dry or managing with 1 light pad for security. So that's continence, and now we'll move on to erections. Now there are these little nerves around the edge of the prostate, and they're really important for erections. And there's no 2 ways about it. about it. Even with perfect erections beforehand, these don't work as well after surgery. And we need to plan for surgery based on the MRI scan and the biopsy results, how hard to work to try and preserve these nerves. Now, if there's no tumour on one side, we can take a nice close line like this, dissecting round the edge of the prostate and leaving the nerves behind and intact. The problem we have if there's any tumour near the edge of the prostate, for example, shown like this in the diagram up close on the left, is that if we take a really close line, there's a risk that we could leave some cancer behind. And of course, the first priority for doing this kind of surgery is to get the cancer out. That's the first priority. The second priority is to preserve continence, and the third priority erections, but in that order. So the safe thing to do on the side where the tumour is near the edge is to leave a bit of a margin, a covering there, to make sure we get the whole thing out. So if we took this approach in somebody who had good erections preoperatively, they would probably have about a 40 to 50% chance of recovering natural erections after surgery, but only 40 to 50%. So if they were in the other half, then there are other things that we can do to help. Viagra, vacuum devices, injections, little pellets that you can put in the end of the penis. These are the kind of things that may sound a little bit wacky at this point, but the reason for mentioning them is that they do work, and that most couples that want to are able to recover a functioning sex life, even if it looks a bit different to what it looked like before surgery. So that's pretty much it. We see men back at a week to 10 days to get the catheter out, and then at a further 6 to 8 weeks in clinic to check the pathology results, make sure the whole thing's removed. We check the PSA again, and that should come down to 0. Occasionally it's not quite down yet at the first appointment, and we check it a few weeks later just to be certain. And we watch it really closely every 3 months for the first year, and then 6 monthly after that for around 5 years. Because in a certain proportion of men, and it depends on the type of cancer at the biopsy, they will experience relapse during the 5 years after surgery. It varies between about 10% and 25% depending on the type of tumour. And the way that we spot that is by the PSA starting to rise, and that's when we then undertake some further staging investigations and consider further treatment if necessary.